All right, today we're doing something a bit different. We're going to step right into the heart of a high-stakes consultant surgical viva. I'll be playing both parts, the tough examiner asking the questions and the candidate who has to navigate the storm. So let's get started.
Right, candidate, let's start. A 68-year-old man comes into the ER. He's got a 6-hour history of a cold, painful, and pale right leg. How do you proceed? Thank you, sir. Well, a presentation like that is a massive red flag for acute limb ischemia. This is a true surgical emergency where, as we know, time is muscle. My approach here has to be simultaneous assessment and resuscitation. While my team is getting IV access and drawing initial bloods, my number one priority is to get to the bedside and figure out if this limb is viable. I do a quick but very focused neurovascular exam, looking for those classic 6 Ps: pain, pallor, pulselessness, but most importantly, any signs of nerve trouble, paresthesia, or paralysis. The 6P, of course, is perishingly cold, which I check against the other leg. The second I find any neurological deficit, like numbness or weakness, I know this limb is seriously threatened. That puts him in Rutherford Class 2, which tells me the clock is ticking and we need to get to the operating room fast.
Sir, to give you a full and structured answer, I'm going to break down my management into 5 key areas. First, I'll cover my immediate assessment and how I'd resuscitate the patient. Second, I'll walk through the preoperative planning and the steps of the femoral embolectomy itself. Third, and this is crucial, I'll discuss how to anticipate and manage reperfusion injury. Fourth, I'll outline my plan for the worst-case scenario if revascularization fails. And finally, I'll cover the essential postoperative care and follow-up.
So, with the diagnosis basically confirmed and the decision to operate made, my whole focus pivots to getting this patient to the operating room safely. This is a time-critical window, so a systematic approach isn't just nice to have, it's absolutely non-negotiable.
Okay, so a few things need to happen all at once. First, we stabilize the patient, get him admitted, make him NPO, nothing by mouth, and secure 2 large-bore IVs to start fluids. At the exact same time, I'm starting medical therapy, a bolus and then an infusion of intravenous heparin. This is so important to stop that clot from extending further down the leg while we're getting ready. Then we start the standard prophylaxis. Next up is communication. I'm on the phone with my anesthesia colleague and giving a heads up to the ICU that we have a potentially very sick patient coming their way. And finally, the logistics. I need to know that blood is cross-matched and ready to go. And I'll personally mark the correct leg with the patient. Every single one of these steps is about minimizing risk before we've even picked up a scalpel.
Now that the patient is stabilized and the prep work is done, the next big step is getting informed consent and moving on to the definitive surgical plan. The name of the game is restoring blood flow as quickly and as safely as we possibly can. And that brings me to probably one of the most important parts of the whole process, the consent conversation. This is not just a piece of paper, it's a really difficult but essential discussion. I'd explain very clearly that our primary goal is to save his lead with a procedure called an embolectomy. But, and this is the hard part, I have to be completely honest about the real possibility that it might not work. So I would explicitly consent him for both an embolectomy and a potential amputation, all in the same sitting. This is to ensure that if we get in there and the limb is just not salvageable, I have the consent to do what's necessary to save his life, without having to wake him up to have that devastating conversation all over again. So, in the OR, here we go. My preference, if possible, is to use local anesthesia. It just reduces the physiological hit on these patients who are often quite elderly and have other health issues. I'll make a vertical groin incision, which gives me great access to the femoral bifurcation. Now, the most critical part of this first step is getting control. I'll carefully dissect out and sling the common, superficial, and profundifemoris arteries with vessel loops. This is the cardinal rule of vascular surgery. You never ever make a hole in a blood vessel until you are 100% certain you can control any bleeding. The real star of this show is the Fogarty catheter. It's a surprisingly simple but incredibly effective tool. It's basically a long, flexible catheter with a tiny inflatable balloon on the tip. The concept is really straightforward. You pass the catheter through the clot, you inflate the balloon just enough to touch the artery wall, and then you gently pull it back, dragging the clot out with it. Okay, once I have control, I'll make a transverse cut in arteriotomy in the common femoral artery. I like a transverse cut because it's less likely to cause a narrowing when I close it up. My first pass is always distally, down the superficial femoral artery, since that's the main highway to the lower leg. The key here is just persistence. I'll repeat the pass again and again until I get 2 clean runs with no clot coming out. Then I do the whole thing over again for the profundifemoris artery. You can't skip this step, it's a vital collateral. And finally, 1 pass proximally just to make sure the inflow is clear. For the closure, I'll use a fine, non-absorbable suture. Right before I tie that last knot, we do a flush by quickly releasing the clamps to kick out any air or tiny bits of debris. Then we restore the flow in a specific order. Inflow first, then outflow. But we're not done yet. The last non-negotiable step is an on-table completion angiogram. Think of it as our quality control check. It's really the only way to be certain we've cleared the clot all the way down to the foot and haven't left anything behind that would just cause the whole thing to fail. So, what if that angiogram isn't perfect? As a consultant, I always have to be thinking one step ahead. If I see a significant amount of clot left in the tibial vessels that I just can't get from the groin, my plan B is an immediate below-knee popliteal artery cutdown. This second incision lets me pass a smaller Fogarty catheter directly into those distal vessels. Honestly, being willing to escalate and do more right then and there is often what makes the difference between success and failure.
Now, even if we successfully get the blood flowing again, we're not out of the woods. In fact, it creates its own massive danger: reperfusion injury. I know examiners love to focus on this because it can be just as dangerous to the limb as the original clot.
See, when blood rushes back into a muscle that's been starved of oxygen, it triggers this huge inflammatory response, which leads to some serious swelling. The problem is, the muscles in our lower leg are packed into 4 very tight, non-stretchy fascial compartments. If swelling happens inside these fixed boxes, the pressure just skyrockets, and it chokes off the blood flow all over again. That is compartmental syndrome, and you diagnose it at the bedside. The leg gets tense, hard as a rock, and it's excruciatingly painful when you passively stretch the muscles. This is another surgical emergency. The only fix for this is an emergency 4-compartment fasciotomy. The standard way to do this is with 2 long incisions, one on the lateral side and one on the medial side. This gives you reliable access to release the pressure in all 4 of those tight fascial compartments. Through that lateral incision, I'll open up the anterior and lateral compartments. The big thing I'm worried about here is finding and protecting the superficial peroneal nerve, which runs right near the neck of the fibula. Then, through a medial incision, I'll release both the superficial and deep posterior compartments. Now, what's really important is that you never close these wounds right away. The muscle is still swollen, and closing the skin would just defeat the whole purpose. So instead, we pack the wounds open and plan to come back to the OR in 48 to 72 hours for a washout and, hopefully, a delayed closure, which often requires a skin graft. Look, despite everything we do, sometimes the limb just can't be saved. The ischemia might have gone on for too long, or our embolectomy just might not work. When that happens, we have to pivot from trying to save the limb to saving the patient's life, and that means amputation. The whole principle behind amputation is to remove all the dead tissue while creating healthy, well-vascularized flaps that can close without any tension. For a below-knee amputation, the go-to technique is the long posterior flap. We save the calf muscles and skin because their blood supply is just much more reliable than the front. This creates a really durable, well-padded stump that's perfect for fitting a prosthesis later on. A below-knee amputation, or a BKA, is always what you want to do if the tissue is healthy enough, because saving the knee joint makes a huge difference in a patient's ability to rehabilitate. Some key steps include creating that long posterior flap, making sure you cut the fibula a bit shorter than the tibia, and beveling the sharp front edge of the tibia. For an above-knee amputation, an AKA, we typically use a fish mouth incision. A critical step in both procedures is how you handle the major nerves. You identify them, you put them on a bit of tension, ligate them, and then let them retract high up into the soft tissues. This one specific step is absolutely key to preventing painful neuromas down the line. The surgery is really just one part of the patient's journey. Comprehensive postoperative care is what really determines the outcome, whether they had a successful revascularization or an amputation. After the operation, this becomes a team effort, which I would lead. It involves meticulous wound and stump care from the nursing staff. Pain management is a huge priority, using multiple different approaches and specifically addressing phantom limb pain if the patient had an amputation. But really, the key to a good outcome is rehab. I'd make sure the physiotherapists are involved from day one to get the patient moving. And for amputees, an early consult with a prosthetics team is absolutely vital to start them on that long road to recovery. And that's the end of our simulated Viva. What I hope this whole case showed you is that when you're in a high-pressure situation like this, having a clear, logical structure is your best friend. It shows the examiner that you're not just rattling off facts, you're a safe, thoughtful surgeon who can manage a complex emergency from the minute they walk in the door to their long-term recovery. It's not just about knowing the steps, it's about showing you can think through the whole problem.